The Jack Welch Management Institute at Strayer University helps you go from, I know the way, to I've arrived with our top 10 ranked online MBA. Gain skills you can learn today and apply tomorrow. Get ready to go from make it happen to made it happen and keep striving. Visit strayer.edu/Jack Welch MBA to learn more. Strayer University is certified to operate in Virginia by Chev and has many campuses, including at 2121 15th Street North in Arlington, Virginia.
Una silla de masajes puede parecer extravagante. 8 configuraciones diferentes, intensidad ajustable, además es calefaccionado. Y se siente tan bien. Sí, una silla de masajes puede parecer extravagante. Y 2, bueno, aún más. Pero cuando esas sillas de masajes vienen con un auto, se vuelven bastante prácticas. El nuevo Volkswagen Tiguan 2025 con funciones premium como los asientos delanteros con masaje disponibles. Solo parece extravagante.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This episode, we are going to be giving quick summaries of our last 10 articles, which were numbers 51 to 60. How are you doing tonight, John?
I'm good. Just finished up a night or a whole day of clinic and ready to go here. How about you?
Doing great. Actually on vacation, so I've been super chill. I won't tell you what I did all day, but it involved a lot of lying around at the beach. So, it was good. It's been a good day.
Was the water cold in the great New England area?
It was perfect. It was refreshing. But the best part about we go to the lake, the best part is there was a bear at the lake sitting in one of the apple trees just hanging out. So I got to watch the bear at close range for a while before he decided to mosey down and go away.
That's kind of cool.
Maybe I'll put a picture of him on our social media.
Yeah, you should put that up.
He's very adorable and also a little scary. So you ready to get into summaries of our articles?
Yeah, let's do it.
All right. So Article 51 that we did quite a few months ago was about fun activities and recovery. The article was called A Brief Measure of Non-Drug Reinforcement Association with Treatment Outcomes During Initial Substance Use Recovery. So it was published in the Journal of Drug and Alcohol Dependence. And a little bit of background is we know that alcohol and drugs produce effects that are rewarding to the individual taking them. That's why they are addictive. And that rewarding nature of drugs and alcohol is amplified when people lack alternative rewarding activities. So the presence of more non-drug reinforcing activities that we call fun activities that don't require drugs, those things may provide an immediate reward and counteract the immediate reward of drug use. So this study was looking at whether higher levels of non-drug reinforcement measures like these fun activities, are they associated with lower rates of return to substance use and higher life satisfaction? This was a survey study of 5,481 people. It was done about a month after they completed treatment for substance use disorder. It was carried out in 87 treatment programs of different types, and the participants were surveyed about time spent in fun activities, how enjoyable and available these activities were, and how satisfied they were with life overall. They then looked to see if there was a correlation between the fun activities and the patient's return to drug use, and then the fun activities and life satisfaction. Just one thing to keep in mind, though, is that more than half of the people in the survey were in treatment for alcohol use disorder, which is less stigmatized than, say, opioid use disorder or methamphetamine use disorder. And those patients may have had a different baseline in terms of recovery capital compared to patients we see. I know you and I mostly treat patients with opioid use disorder who really blow up their lives and eliminate all fun activities by their drug use. So I thought this was a valid trial. It was just looking at an association between the fun activities and recovery. It wasn't designed to prove that an intervention providing fun activities would actually lead to better recovery. So really an association study, not a causation study. And also it was just a single point in time survey. So it couldn't consider access to and enjoyability of the fun activities prior to the study. And different substance users may have different starting amounts of recovery capital, different sort of baselines. So there were a few caveats to this survey. But I still think it was a valid study. It was really big. The questions were well done. So what did they find? So there were 4 main results, but to summarize it all in one sentence, as you might guess, is all three fun activity indices, which is frequency, access, and enjoyability, robustly predicted lower levels of return to substance use after a month after discharge from treatment. So the primary outcome was a correlation between return to use and availability of fun activities. So as availability and enjoyability declined, return to use went up. A little bit of a chicken and the egg problem, though. So, is lack of fun activities causing return to use, or is return to use causing lack of time spent in fun activities? If you return to use, you might find that fun activities are less enjoyable, harder to get since you're spending your time and money on substances. Hard to say if the fun activities are protective. They may have just been a signal that you're doing well rather than a protective thing. So I guess I feel like I kind of would have guessed it. There was lower life satisfaction among people with less access to non-drug activities. People who return to use spent a higher proportion of their time using drugs. Not a surprise there. And they also had less access to fun activities. So how will this help me? Basically, I want to support people in recovery, especially people in longer term recovery, and do relapse prevention, support them um, in staying sober, and it really sort of reinforced and strengthened some initiatives I've put in to encourage these fun activities. So with patients now, I talk about things like outdoor activities in the summer, engaging in art. I've recommended books to read. We've helped organize some special sessions at a local gym, just a few extra things outside the doctor visit. And I don't think they're going to make or break someone's recovery, but at least they're fun. And my patients don't always get to do a lot of fun things. So this article actually did change my practice in terms of me supporting and facilitating some of these non drug activities. How about you, John? Did you find that this article changed your practice?
Yeah, I feel like the longer I've been doing this, the more I feel like I kind of find some of this stuff really useful. I almost feel like recovery is like a ladder. And I feel like that a lot of time at the beginning of the ladder is like the acute withdrawal, kind of stabilization, kind of getting people out of these in extremist lifestyles where they're in contact with court systems, they have debt, or they have issues that just make kind of living life very difficult. But like I see my patients in recovery a lot, even people that I've seen like 8 years at this point. I've had a couple patients, and I kind of run out of things to talk out with them at the visits, but I still have a visit with them. So I feel like a lot of visits I do transition over to talking about, like personal wellness, things to keep them happy. It was actually interesting yesterday. At my clinic, one of the patients I had for a while, we actually were going through the process of him exploring like college classes through his work, just because he's been stable with me for like 8 years. I feel like that's something that would help him a lot. And we kind of walked through the website and kind of went through some of the stuff there. So I thought that was kind of cool. We told him he's going to get the dad talk today, that it's no, he's capable of much more. So I think it's great to look at these kind of like metrics beyond kind of urine drug screens and other things besides just medications or counseling as part of your recovery plan, like your global wellness.
Yeah, and a tiny bit off topic, but I find I learn so much about my patients. I usually ask them about their health and keep it pretty businesslike. But, I went through a thing where I asked every patient what was their favorite activity to do in the summer. And people told me so much cool stuff. And I learned all these things about people that I didn't know, like what they were into, where they like to travel. This guy's into fishing. This other person's really into the beach, just all these things I didn't know about. And it gives you a great way to get to know people a little better.
That's a good idea. Maybe I want to introduce like a fun question of the week.
Yeah, well, and I introduced it, but then I kept a list of people's answers, and the list grew as the month went on, and I shared the list with everybody. So I was like, here's everybody's free fun summer activities in central Pennsylvania. And it was kind of cool. All right, you want to tell us about our next article?
Yeah, episode 52 was buprenorphine-precipitated withdrawal among hospitalized patients using fentanyl. It was from JAMA Network Open from September 2024. The clinical question here, or questions, was one, what is the incidence of buprenorphine precipitated withdrawal in the emergency department and hospitalized patients with opioid use disorder? Two is, how do initial withdrawal severity, your CAL scores, your buprenorphine dose, your BMI, and your urine fentanyl concentration affect precipitated withdrawal risk? And three, what are the implications of precipitated withdrawal for care retention? So it's like threefold. And I think it's interesting. We talk a lot about this in other podcast episodes. So, like precipitated withdrawal. I mean, it does have a textbook definition of a CAL score increase to a certain points within a certain window of time frame. But I think patients bring this up all the time, and I feel like every abnormality or odd sensation or ache or pain at times can kind of be attributed to this. So it's hard. I'm happy to get some data on like what truly the incidence is of precipitated withdrawal, especially, we're almost restudying everything that we studied before now in the fentanyl era, knowing that it behaves differently. So the methods, this was a retrospective cohort study of 226 adults with opioid use disorder assessed for precipitated withdrawal after buprenorphine initiation in the emergency department or inpatient setting across 3 urban hospitals in Philadelphia from 2020 to 2021. Researchers analyzed incidents of precipitated withdrawal, and they count that as a CAL score greater than or equal to 5-point increase within 4 hours of dosing. So that's kind of the definition. And they examined the association of the CAL score, initial dose, BMI, and urine fentanyl levels with chance of precipitated withdrawal. The results, precipitated withdrawal incidence as a whole occurred in 26 patients. That was 11.5% in the primary cohort. But actually, when you go into this fentanyl positive subgroup, it is much higher. It's 16.3% met criteria for precipitated withdrawal. I thought it was very interesting. There was no significant association between precipitated withdrawal, initial CAL score, buprenorphine dose, or BMI in the cohort, which kind of blows some of my previous assumptions here. You thought that there was a dose association with it. Particularly, we talk about this kind of dangerous middle ground, like 8 milligram dosage. We thought that typically kind of the larger patients have more fentanyl kind of soaked up in their adipocytes, so that that's a more difficult group to induce, but that wasn't what was found. When you look specifically, kind of breaking things down in just the fentanyl positive subgroup, that's where you did have an association with kind of the BMI and the high urine fentanyl concentrations. So people with high initial urine fentanyl concentrations and high BMI, so obese patients greater than 30, that did raise your risk of precipitated withdrawal with an odds ratio of about 5.12 to 8.37. And it basically showed that even when you kind of redid the sensitivity analysis, filling in missing CALS data, there was still a very significant association between precipitated withdrawal in the fentanyl positive only subgroup, with kind of the patient's baseline weight with higher BMIs having more likelihood of precipitated withdrawal and higher urine fentanyl concentration. I kind of take this away as interestingly so I now know and I can counsel my patients that are kind of starting buprenorphine, about 1 in 9 will develop a risk of precipitated withdrawal. And if they're predominantly using fentanyl or fentanyl contaminated strains and they have a higher BMI, and especially with kind of recent last use, the chance is going to be higher, possibly up to about 1 in 5. So it does kind of challenge some of those assumptions and give me some guidance for kind of mitigating and kind of managing expectations with patients, which I think is really important with this induction phase. What do you think, Sonia?
Yeah, I mean, I just think data is good. Precipitated withdrawal is becoming more common, and it's nice to be able to actually give people some hard data, counsel them about what to expect, and maybe even make it less fearsome. If we can't prevent it 100%, at least we can prepare people for it, so they're less surprised by it. So yeah, I think this was a good paper. Ready for the next one?
Yep.
All right. Number 53 was methadone versus buprenorphine. It was a paper published in JAMA. So buprenorphine, naloxone versus methadone for the treatment of opioid use disorder. This is a new study, big study in the era of fentanyl, comparing these two main treatments for opioid use disorder. So these are the two best treatments available, methadone or buprenorphine. But there's not a lot of comparative effectiveness research, and previous data on methadone didn't include patients who were using fentanyl, and on many different sort of subgroups of patients. So there's not really comprehensive data. In general, though, methadone seems to promote better retention and treatment than buprenorphine. But in the US, methadone's strict regulations make methadone treatment really burdensome and complicated and inaccessible to many people in the US. So even though it's the most effective treatment, it's not used as much as it could be. And it's also hard to compare to buprenorphine, which doesn't have all these restrictions on it. So this was a population-based retrospective cohort study comparing patients on methadone and patients on buprenorphine naloxone, with the primary outcome being treatment discontinuation and mortality. And just of note, this was done in British Columbia, where methadone and buprenorphine are regulated similarly, so the treatment experience is similar for the patients. So the population was adults with diagnosis of opioid use disorder and no prior attempt at opioid addiction treatment in the past 14 years. They did a secondary group of people who with no treatment just in the last 30 days as well, but mostly they were people coming to treatment new without any previous treatment. It took place in British Columbia between 2010 and 2020, and As I said, methadone and buprenorphine are prescribed similarly in British Columbia. They're both prescribed in office-based settings, dispensed by pharmacies. Up to 2 weeks of take-homes are allowed after 3 months on methadone and immediately for buprenorphine. The exposure they looked at was exposure to buprenorphine naloxone combo, which was 39% of patients, and compared to methadone, which was 61% of patients. And again, these are people getting these medications for the first time. Outcomes were treatment discontinuation and all-cause mortality, and they followed patients for 24 months. I thought this was a great trial. It was large size. It had very careful statistical analysis. Weakness that it was retrospective rather than a randomized controlled trial. It means that those who chose methadone may have been different than those who chose buprenorphine at baseline, although in Canada, the differences would be less stark than in the US. Bottom line of this study, to quote the authors here, for patients who are taking medication for the first time, they say the risk of treatment discontinuation was higher among recipients of buprenorphine naloxone compared with methadone, with 88.8 versus 81.5% within 24 months, with a hazard ratio of 1.58. Risk of mortality was low and not statistically different while in either form of treatment. So 0.08% versus 0.13% with a hazard ratio of 0.57. So basically, the methadone kept patients in treatment more. More patients stayed in treatment on methadone than on buprenorphine, but there was no mortality difference. The patients who started the medicine just after a gap of 30 days, so people who'd used it before, risk of treatment discontinuation was 91% among patients with buprenorphine and 85% among patients who received methadone. So again, same kind of finding. And mortality was low in this group overall, 3% in the buprenorphine group and 2.5% in the methadone group. So again, that mortality comparison is kind of uncertain. So you really can't say methadone offers a mortality benefit, but it does offer a treatment retention benefit. So this study kind of confirms previous data, but it's using newer settings, newer drugs like fentanyl, and in a Canadian setting. So I think it adds to the literature. And I personally can't prescribe methadone, but bottom line, it seems like it's very effective. Yet, um, but a viable treatment. And so any patient who's interested, I will counsel that it's as effective, if not more than buprenorphine, and I'm happy to recommend a place to get it. And yet I'm hoping that methadone will be deregulated, and then I'm hoping our employer at St. Max's will let me open an office-based, primary care-based methadone clinic. You with me, John?
Do it and ask forgiveness later.
Okay, right. We don't even ask. No one knows we're gonna do this. Everybody just
Assume best intent.
That's right. Just
Proce-
keep it to yourselves if you're
and
listening to this
proceed until told
podcast.
to stop.
Yeah. Just start prescribing it, and then 7 months later, somebody notices and asks what we're doing. We're like, "I don't know. Just doing our
Saving
job,
lives. Saving
saving
lives.
lives." Yeah. You
Yeah.
got a problem with that?
I like this article because I feel like the key thing was doing this in Canada, right? Because I think that I often attribute the differences in outcome between the two treatments to the dichotomy of patient experience, right? I feel like one of my CRSs used to say that, the um, the answer to chaos is structure and order. And that with the way the methadone programs are here in the United States, they're just so structured. And sometimes I thought it was that actually made the difference, not the medication. But taking that out of the equation here, it's interesting that methadone did kind of come ahead here, at least in the retention component.
Yeah. Yeah, it's true. I would sort of agree. And also, like, methadone is such a pain to get, and you have to really be committed. A lot of patients, I think, go to methadone. They're truly ready to, commit to sobriety because it's a big commitment. All right, next.
Episode 54. So this is Association of Daily Buprenorphine with Urgent Healthcare Utilization. It's from JAMA Network Open from September 2024. The clinical question is buprenorphine treatment at higher doses than the FDA recommended 16 milligrams per day associated with reduced emergency department or inpatient behavioral health visits among individuals with opioid use disorder? So are we decreasing our healthcare utilization by going beyond that 16 milligram threshold? This was a retrospective cross-sectional study of 35,451 commercially insured U.S. adults with opioid use disorder, and it analyzed whether higher daily buprenorphine doses were linked to delayed or reduced ED inpatient visits for behavioral health conditions. So the data came from the Optimum Cliniformatics Data Mart and excluded Medicare and Medicaid fee-for-service populations. It was conducted between 2016 and 2021. So the results, I thought this is very interesting. In terms of dose and utilization, patients on greater than or equal to 24 milligrams per day had the longest delay in ED or inpatient visits compared to those in the 8 to 16 milligram dosage groups. So the higher the dose, the longer interval between presentation to your ED or inpatient setting. The 16 to 24 milligram dose group also had significantly longer times to urgent care use. So that also is statistically significant. And these differences is more evident as time actually progressed. So it wasn't kind of that initial stabilization phase. It was kind of more evident after the 6 month period of time when the groups would kind of diverge. And, the 24 milligram group actually had the largest effect size after a year. So really kind of like it was even the delayed time beyond that to maximum benefit. Interestingly or non-interestingly, men and those with prior opioid use diagnosis had longer times to urgent care use. Patients with mental health or non-opioid substance use diagnosis had shorter times to ED or inpatient visits, and buprenorphine discontinuation was paradoxically associated with delayed urgent care, likely reflecting kind of censored follow-up times or patient disengagement and with the system as a whole. So the conclusion here is that doses 16 milligrams or going beyond that in cases where it's very appropriate actually does have health benefits beyond kind of just patient satisfaction and also the immediate patient effects. It kind of reduces system use, it delays or reduces our acute healthcare and behavioral health utilization. And it really is something to probably consider as a strategy to kind of prevent unnecessary healthcare utilization kind of moving forward in our system. So I took away from this, I don't really get too bent out of shape anymore going beyond 16 milligrams. I think at one point in my younger career, that used to bother me when I went above 16 because the data showed it made no difference. But I think the data, the practice trends, and now some experience just having patients on this dose, they do just as well, if not better, if they need it. And there's no harm at going up to that 24 milligram dose.
All right, it's just more data showing the higher doses are better than the lower doses. And it's just, even if I'm sometimes a little uncomfortable with how high the doses are, there's just incontrovertible that that's the data shows they're more effective. And I haven't seen any papers showing that the higher doses are less effective or worse. No, I haven't seen anything.
We're truly Americans, right? More is better.
More is always better. Well, so here's the question though, because like I remember, and maybe this was just this one conference, but like the very first addiction conference I went to, it was like a 1 day Pennsylvania State conference or something, just 1 day. And someone who was doing buprenorphine stood up, and this would have been in like 2011 or something, and said that she didn't have any patients on any greater than 8 milligrams. There was no reason anyone needed anything more than 8 milligrams a day. And for the first few years of my practice, that was pretty true. And so do you think that back then we were just underdosing everybody, or because they weren't taking fentanyl, they never got to the point where they needed 24, and now people need the 24 because 'cause they've been taking fentanyl?
I mean, everyone was dying,
Yeah,
right? I mean, I think we were under treating. It's like blood pressure, where our blood pressure target was 160 over 90. It wasn't even close to reality, right? So I think we've learned over time that no, and this is an evolving field, right? We talk about this all the time. It doesn't have the luxury of heavy industry funding in terms of studying like other fields of medicine. There's a lot of retrospective and case reports and insurance database kind of trials. Like we didn't have that data to know any better, and I think now we know, and everyone's comfortable with it, right? Because
yeah.
it's fine and people do better.
Well, right, and I wonder if some of the trend in mortality that's been improved over the last 2 years, I mean, I think the availability in higher doses of buprenorphine has been part of that, you know?
Definitely, right?
Yeah.
We were under treating. It's more of a, I mean, it's easier to get a buprenorphine script. I think that most of us have also, it's less stigmatizing. People are
Right.
treated like patients. I think people don't have to go to a clinic where they sit and they feel judged and the doctor just talks about their opioid use disorder and, you got to leave your urine or it better be good. And we call it clean or you don't
Right.
get your medication. Like we don't, we're phasing those people out. Right. And it's just kind of, you go to your regular doctor for treatment who cares about you and wants you to do well.
Yeah, and it's the thing that really helps me, I have to say, and maybe, I'll put this out there to anyone who might be listening who doesn't prescribe buprenorphine. It's so safe. It is just so safe. And the more you give, the safer your patients are. So unlike other opioids where it's like the more you give, the less safe your patient is, it's like the opposite. So it just the more you give, the better people do and the safer they are. So I just, I'll say that again. And that always helps me be comfy with the higher doses. Although I don't know, am I ready to go up to 32 for everybody? next? Is that the next phase?
I haven't had that scenario yet, but I mean, if the clinical situation was right, there's data that beyond that, right? There is studies showing higher and higher than that. I think I've seen some up to like 48 milligrams, which is really high. And, I've never even come close to that. I've never to go beyond 24. But I think if someone was still struggling and, you know, they were trying and I was working with them and they felt they needed it, I would give it a try.
All right. We'll check back in a year, see what the data shows. Um, our next paper is also number 55, also about buprenorphine dosing, but this time in pregnancy. So, this was an article called A Pharmacologic Evaluation of Buprenorphine in Pregnancy in the Postpartum Period. It was published in the Journal of Addiction Medicine. So, buprenorphine is standard of care for pregnant people, and there are some physiologic changes in pregnancy that might be associated with different dosing needs. But the package insert for buprenorphine doesn't really recommend different dosing amounts or frequency in pregnancy. So, as you may have seen in practice, despite its 48-hour half-life, many patients feel that the buprenorphine kind of wears off after 8 to 12 hours, and they prefer more frequent dosing. The authors observed that when patients were encouraged to choose their dosing frequency, many pregnant people chose 3 or 4 times a day rather than daily or twice a day. And so, with that in mind, the authors of this paper wanted to study this unique sort of pharmacokinetics and the pharmacodynamics of buprenorphine in pregnancy. So, this was a little different than our usual studies. It was a prospective cohort study. It had 22 people in it, so a very small group, and they were taking buprenorphine for opioid use disorder. They brought them all into the lab, and they basically took blood tests every few hours, as well as doing physical exams to look at their pupil diameter, their COWS score, their craving score, before their very first dose of the day, and then every few hours throughout an entire day, 6 to 8 hours until their next dose of buprenorphine and a little bit beyond. So they did this to patients in the first half of pregnancy, in the second half of pregnancy, and then after birth. So a real true pharmacokinetic and pharmacodynamic study. And what they were looking for was a correlation between plasma buprenorphine levels and then these symptoms of withdrawal like pupil diameter, COWS score, and craving score. It showed that pregnant people required higher doses of buprenorphine. So bottom line, higher doses of buprenorphine to achieve concentrations comparable to non-pregnant people. And there's a temporal relationship between the plasma buprenorphine concentration and the pharmacodynamic markers of pupillary withdrawal, COWS, and craving score. So you could really see as the buprenorphine level went down a few hours after that dose, pupils dilated, COWS score went up, and craving score went up. So put another way, these pregnant people had lower bup concentrations than non-pregnant people who took the same dose, meaning they might need a higher dose to achieve the same blood levels that they had before they became pregnant. The other thing that was really interesting was seeing how these physical markers of withdrawal moved in sync with the buprenorphine concentration. So it really did change my idea of how this works. So when a patient say that their buprenorphine is wearing off, this does correlate with lower blood levels. It's not something psychological. I used to really think that like it has a 48-hour half-life. How can it wear off in 3 hours? But this study really shows that as those levels decline, you start to feel it even though you're not even at the half-life yet. And the blood level at which these pharmacodynamic markers return to normal was about 1 nanogram per milliliter. So they really just emphasize that dosing of pregnant people should not be based on studies of non-pregnant people and, calls it supports calls for higher dosing recommendations in pregnancy. Um, because clinical studies do show that there's better retention in treatment if you give higher doses during pregnancy. But this is a pharmacologic study, so it really kind of quote unquote proves that concept. It also shows that a single daily dose or even twice a day dose may not maintain that plasma concentration above 1 nanogram per milliliter for a pregnant woman. So this study definitely changed my practice in that I will tell pregnant women off the bat they might feel better with 3 or 4 times a day dosing if they want. And I'll check in throughout pregnancy on their symptoms of craving and withdrawal. And I've actually done that now for non-pregnant patients I think some people just kind of burn through the buprenorphine more quickly and would do better with 3 or 4 times a day dosing. I mean, it can be inconvenient. You got to bring it with you then to work, and then you got to have this whole thing under your tongue for like 10 minutes. That might make it feel weird to talk. So it's not always convenient to take it 4 times a day, but I offer that as an option to people who feel like it's not quite holding them. Sometimes rather than increase the dose, I say, let's just split it and see if that works better. So I thought this was a really great study. Did you like this study, John, or have you used it in your practice?
No, I think it kind of tracks with I think what we see a lot though with our kind of pregnant patients. And you're right. I think that again, back to kind of changing thinking patterns even over the past like 5 years, like what we think of as how patients experience and dose fluctuations and some of these things that our patients have been telling us that maybe we haven't always been taking seriously. There clearly is some physiology here that it's real. There's a real reason for this, and we should be listening.
Yeah, exactly.
Okay. Next one I have. This one I really like. It's episode 56. It's articles titled Beyond the First Try. How many quit attempts are necessary to achieve substance use cessation? It was from Drug and Alcohol Dependence from December 2024. The clinical questions were one, how many quit attempts does it typically take to achieve abstinence from a substance use disorder? And two, what factors are associated with the number of quit attempts before achieving abstinence? So the methods here, this was a cross-sectional observation study that surveyed 421 adults recovering from substance use disorder through the International Quit and Recovery Registry, the IQRR, to assess the number of quit attempts before achieving abstinence and factors influencing quit frequency. I think the results were very interesting. So when you look at number quit attempts per substance to be successful, the highest number of quit attempts on average are required for number one, alcohol, which averaged 10.9 quit attempts before success, opioids 10.4, and nicotine 7.5. The lowest was hallucinogens, which is 3.9 quit attempts prior to quit. Key factors that were identified regarding quit attempts were kind of substance use type, clearly. So, alcohol and opioids had significantly more attempts than the other substances. Substance use severity, so intuitively, more severe substance use disorder or more attempts required for success. Younger age at first use was highly associated with more quit attempts and longer duration of use. So, younger, longer, more severe, more quit attempts, kind of what we hear in the office every day. The conclusion here that I took away is, and this kind of piggybacks a trial that we talked about in one of our lectures at VCU, where they talked about nicotine, for example. Like 7.5 is conservative. The other trial said 10 to 25 quit attempts for success. I think that this really shows people that achieving abstinence from any substance use disorder really requires a lot of attempts, and that just because you failed once or weren't successful by your definition, that doesn't mean that future attempts are going to be futile. So I recommend and I kind of counsel people that kind of failed quit attempts are part of the process. And even tonight, this wasn't in my medication for opioid use disorder clinic. This was just my general clinic. I had a patient for a well visit, and they were talking about his smoking. And, he said he's tried 2 or 3 times. And I was like, well, I read a study recently that showed that, on average to successfully quit, 10 to 25 times to try to quit smoking. And the look on his face of like relief that he just didn't feel like a loser and that he wasn't successful and that he couldn't do this. I'm like, this is part of the process, man. I'm like, you just got to keep trying. And I just feel like I could just tell he's like, yeah, I'm going to try to cut back. And then the whole conversation was about, how he's going to try to wean down over the coming weeks for his family and for his kids, which are young. He's a younger guy. And I think that just letting people know that that's expected, it's really important. And I think that people just feel empowered again.
Well, right. And you've always said like managing expectations is a big part of primary care. Often, it's in a negative light, like telling people they're not going to get what they want. But this is one of these ways in which you can manage expectations and give people kind of a positive boost. Like just because it didn't work, that you're like you're not even at the average yet, man. Like you have so many chances to do this. And you're still doing, if it takes you 6 times to quit, you'll still be better than average. Yeah, I thought it was good.
There's a good piggyback. I feel like like literally that was a patient I saw an hour and a half ago. And like, I just saw in his face, like it was like relief. Like he
Yeah.
just felt like it's like, oh, okay. So I don't know. It's good information to use.
Well, and I think it's just like quitting any substance. It's just like any big behavior change. It's rarely once and done, you know? Like anything you wanna change about yourself, it takes a bunch of tries and a bunch of, just iterations to get it to stick. So, yeah, I thought that was a good study too. All right, ready for are we up to number 57?
Yeah.
What is recovery? So, this was a super nice study. It was called Understanding the Shared Meaning of Recovery from Substance Use Disorders New Findings from the What is Recovery study. And it was published in the Journal of Substance Abuse. We talk about survival of and recovery from substance use disorder. It often requires significant life changes, like we were just saying. And making and maintaining these changes is referred to as your recovery. But it can mean different things to different people, and experiences vary widely. So we've been moving away from just the recovery equals drug abstinence concept for a while, but a new common definition doesn't really exist. So the authors of this study, the What is Recovery study, set out to determine how people in recovery themselves defined their recovery. They used a questionnaire, 35 items reflecting 4 domains of recovery, and the participants reported whether or not each element of these 35 elements belonged in their recovery definition. And then they ranked the items according to how often they were scored. So it's a pretty simple study. It was a big group, 9,341 people who self identified as being in recovery. Most of them were in recovery from alcohol use, about 60%. Only about 10% from crack or cocaine, 7% from heroin. So alcohol heavy group. And keep that in mind when you look at the results, because a lot of people who struggle with alcohol use disorder, their recovery is heavily influenced by AA and the precepts of recovery found in AA. So they determined which items met what they would call it a centrality threshold, meaning it was endorsed by more than 80% of all subgroups. And then they classified items as core if they met that centrality threshold for all subgroups, and prevalent if they met this threshold for up to 26 or more of the 30 subgroups. I thought this was really valid, had a lot of strengths, including its large size, its broad recruitment. Inclusion of the elements was developed from the recovery community itself. But there's also ambiguity. If one of the elements is being honest with yourself, what does that mean to people? It could mean different things to different people. And also, perceptions of a meaningful recovery really could change over time based on culture, resources, and the drug supply. For a lot of patients with opioid use disorder, total abstinence needs to be part of recovery. It seems it's hard to use fentanyl occasionally, recreationally. Whereas a lot of patients with, say, alcohol use disorder might have a recovery that includes weekly or even daily moderate alcohol use. Also, over time, the study started in 2012, and the definition of recovery, already has changed since then. I think that's one of the downsides of this study. But anyway, what are the results? The 4 core elements that were found in all subgroups to be in the top 10 were: recovery is a process of growth and development, of being honest with oneself, of taking responsibility for the things that one can change, and of reacting in a more balanced way. The next 4, which were endorsed by at least 80% of people in most subgroups, were being able to enjoy life without substance use, being able to handle negative feelings without substance use, abstinence, there it is at number 7, or non-problematic substance use, and living a life that contributes to society, family, or your own betterment. So the clinical implications here, I thought were pretty profound. Most people said that some abstinence goal should be part of recovery, and it did make the top 8, but it really was not very highly ranked by a lot of people. And these aspects of recovery, like personal integrity or honesty, they're not mentioned in any of the definitions of recovery put forward by groups like the American Society of Addiction Medicine. um, they didn't even include things like honesty and personal integrity. So there's really some novel elements here that we should pay attention to. And so the way it changes my practice is that I'll just do my best to address these aspects of recovery in the context of my office visits. I won't de emphasize abstinence, but I really will let people know that recovery is more than just being drug free. And, we work with a lot of peer recovery support specialists who can help patients on some of these other aspects of recovery, especially getting to the point where you can live a life, you know, where you take responsibility for yourself and the things you can change, where you can react without drugs. You can grow and develop and live an honest life. So I really like this study. What do you think, John? Did this study change your mindset about recovery?
I think this kind of contributes to a growing mindset I've kind of shifted to over time, like de-emphasizing urine drug screens and as like as a marker of success. I love the fact that like the top four didn't have anything to do with substance use, right? Like those are things that I think all of us would strive for, which I think kind of undermines like the whole idea. I think what people really want with recovery is to be just like the rest of us and to feel normal and to kind of pursue the same things of happiness that we're all looking for.
Right.
Like those four things I would talk to anyone about, not just, my patients in recovery.
Well, true. Anyone who's struggling or wants to change their life or live a better life, those would be the elements of a good life.
Or just any self-help book. Like I'm gonna get my MBA now. These are all things we would talk about in any one of these articles about like leadership styles. Like these would all be top four things that, they talk about for that subgroup as well.
Ooh, I sense a seminar you could run for the medical leadership types, but ooh, charge big bucks for it.
Yeah, I'm sure they would love what I have to say.
Oh, they would. Totally.
All right. Episode 58. This one was kind of anticipated for quite some time. It's once weekly semaglutide in adults with alcohol use disorder. This was the randomized clinical trial that we've all been looking for. It was from JAMA Psychiatry from February 2025. The question was, do GLP-1 agonists, specifically semaglutide, reduce alcohol consumption and craving in adults with alcohol use disorder? So this is a phase 2 trial, so not our typical research study. So it was a double-blind randomized trial involving 48 non-treatment seeking adults with alcohol use disorder to evaluate the effect of once weekly semaglutide over 9 weeks on alcohol consumption, cravings, and related outcomes using both outpatient and lab-based assessments. So small. So this is like an exploratory study that's going to kind of feather into eventually a phase 3 trial. I think it's important to emphasize that these were non-treatment seeking adults. So I think with like alcohol use disorder, kind of, patient motivation is very important. And this group, while meeting criteria for alcohol use disorder, this wasn't really what they weren't looking really necessarily to stop their alcohol use. So I think that kind of already spins the trial to make it harder to prove an association. So the results here, the primary outcomes, they did this laboratory alcohol self-administration test, which was really kind of cool. They basically had people come into a facility. They had to drink their drink of choice, whatever that would be, at their own cadence until a desired level. And they measured like how quickly you drank, how much total alcohol you consumed. And they looked at things like breath alcohol concentration. And what they showed is that the group with the semaglutide had statistically significant reductions in grams of alcohol consumed when this test was repeated, and also significant reductions in peak breath alcohol concentration. In terms of secondary outcomes, in terms of drinks per day, there was a reduction in weekly alcohol cravings, drinks per day. Heavy drinking days decreased over time. They had this exploratory outcome for cigarette use among smokers. And actually, there was a statistically significant association there, although this was a very, very small subgroup in a 48 participant trial, the subjects or it's 48 subject trial. So, I mean, I think that's an interesting outcome. I don't know if I would take that one to the bank just yet, since it's like a subgroup analysis of a subgroup, essentially. Not surprisingly, there was a small weight loss in the semaglutide group. So I think anyone that watches Celebrity Bachelor or whatever would tell you that they know that already. There was really no significant changes in kind of overall drinks per day. So like heavy days of drinking, there was a reduction, but overall average drinks per day over the trial did not really change. Abstinent days didn't change. A1C, blood pressure, depression scores. And interestingly, I do see more and more case reports about a concern with association with these drugs with kind of mental health outcomes like depression. So, very similar to a lot of our other currently available medications for alcohol use disorder, right? Substantial reductions in alcohol consumption, heavy drinking days, but not really abstinence-based medication. So I think in conclusion, I still think this is a very interesting medication. I think it's got a lot of future in our healthcare system with kind of approvals for almost everything. It seems like at this point, there's FDA approvals for sleep apnea, diabetes, obesity. I saw that there's one now for cardiovascular disease. And I think alcohol use disorder may be our next tool in the toolbox when that gets approval. So I'm interested to have something else to use for patients, especially something with a positive image currently where people really want to be on these medications. I'd be interested to see what the phase 3 shows.
Right. I mean, that's the big thing is people would love to take this medication. Like I've had a few patients who can't tolerate it or it doesn't seem to help them. But like the vast majority really, really find value, even if they have side effects like intractable nausea, they still want to stay on it. I say, you don't have to stay on it. We could try something else. Oh no, I'm not going to stop it. Like they really like it.
Yeah, I
I
agree.
mean, I kind of feel like imagine if a torvastatin worked for like alcohol use disorder, people would still like reject it.
Those poor statins, man. Everyone, I feel like people don't even try them. They're like, oh, I licked the bottle. I got muscle aches.
I know.
I'm like, you didn't even try it, man.
Oh man. No, this is it's super exciting. I was everybody wants these medications and so I'm looking forward to even more, broadening out the indications for it.
Yeah.
I haven't ever able have you been able to prescribe it for alcohol use disorder yet?
Yeah. It's like the person with they have the A1C of like 5.7 and the fasting glucose of 127. And you're like,
Mhm.
oh, that's diabetic.
Were you really fasting when you Yeah. Oh my
Ooh.
gosh. Well, I haven't ever prescribed it just for that main indication, but I have a note to myself to start asking my patients on it how it's affected their drinking and smoking and other compulsive behavior, you
I
know?
do I do ask that about I don't ask about smoking, but I ask them if they drink less. And like literally people immediately like, absolutely. I did notice that. And like they don't even they're like it's like a light bulb. Like I didn't realize I am drinking less, whatever on the weekend. And
Yeah.
so I think it does have an effect there substantially. I think it's not an abstinence only medication. So I think it will have a role. I don't think it's gonna be everything, but it's gonna be something. All right, last question. Do you know where they got semaglutide from? Like where they isolated the GLP-1 agonist from?
Uh-uh.
It's from Gila monster spit.
Oh, I was gonna say armadillos, but that's tuberculosis. Gila monsters, how do they know to look there for the semaglutide?
I don't know that fact yet.
All right, next time, if anybody knows that, let us know. You can post it on Facebook.
Yeah.
Oh my gosh, poor Gila monsters. All right, number 59. Anyone who's still on the podcast is doing great. We're almost done. Number 59, low-dose buprenorphine initiation or micro-induction. This was a paper titled Outpatient Low-Dose Initiation of Buprenorphine for People Using Fentanyl in JAMA Network Open, January 2025. So we all know that high potency, long acting opioids in the drug supply, like fentanyl, make starting buprenorphine more challenging due to precipitated withdrawal. Like you said, John, about 1 in 9, 1 in 8, some other studies say, of buprenorphine initiations in the hospital setting end in precipitated withdrawal. So, a pretty common problem. And there's been a lot of strategies developed to reduce this risk. And one of these is microinduction, where you overlap your fentanyl or a full opioid agonist with the buprenorphine. So you take little bits of buprenorphine and you slowly ramp it up until you get to your full dose of buprenorphine, and only then do you need to stop the fentanyl. And the point is to avoid that kind of precipitated withdrawal. So this was a study testing two different low dose initiation protocols. It was a retrospective cohort study, and basically patients could choose which protocol they wanted. They did a 4-day and a 7-day protocol, and the outcomes were successful buprenorphine initiation and retention in treatment. Pretty good size, 126 people with 175 initiation attempts. They were all at two safety net addiction clinics in San Francisco. And again, just to point out, this wasn't a study comparing low dose initiation to regular initiation. It was just a descriptive study of these two different low dose initiation protocols, comparing which one worked better. Primary outcome, again, successful buprenorphine initiation defined as self reported completion of the initiation protocol, and then retention and treatment as defined by pickup of a buprenorphine prescription within a month of initiation. I thought this was a good trial. The biggest problem wasn't really with the study itself. It's just it didn't quite answer the question I wanted, which was, is a low dose initiation protocol better than a regular protocol? And there's a lot of self selection. Patients selected into this protocol, meaning that they probably had some inkling that it would be more successful for them. So hard to generalize to patients who've never tried anything like this before. In terms of the results, I thought they were pretty impressive given that this was a very, very population with a lot of risk factors for poor outcomes. So, a lot of patients who were homeless. This was a safety net clinic, many, many long term drug use, many tries at abstinence. 70% of patients had tried to start buprenorphine in the past in this study. So this is a group that doesn't tend to do well. And of the 175 attempts, 34% successfully initiated buprenorphine. And 22% were retained in treatment at 28 days. So that's pretty good for a super high challenge group. The 22% were still in treatment a month later, and 34% successfully got on buprenorphine. In terms of comparing the two protocols, the 7-day protocol, 28% had successful initiation, and the 4-day protocol, 33% did. And in terms of retention and treatment, 18% in the 7-day protocol and 21% in the 4-day protocol. So, the 4-day protocol seemed to work a little better than the 7-day protocol. So pretty good outcome, I think. If you talk about precipitated withdrawal, it occurred in about 10 cases, although it didn't have perfect follow-up. A lot of patients were lost to follow-up. So 8% of the initiations where they did follow up with people, there was precipitated withdrawal. And of these 7 of these cases, they had deviated from the protocol. So there were only 3 cases with follow-up, so about 3% in which precipitated withdrawal occurred when people followed the protocol. So I think that's pretty good. It makes me feel confident that if people follow this protocol, the rate of precipitated withdrawal is pretty low. So in conclusion, it's not going to lead me to promote this low dose initiation protocol over a traditional initiation because that isn't what they studied. But if a patient really has a strong fear of precipitated withdrawal or requests this protocol, I'd be happy to have them use it. I'll tell them it has about a 1 in 3 chance of success, at least based on this study. And they can choose 4 or 7 days, but the 4-day protocol is a little more successful and probably a little easier to do. And the paper, for anyone who wants, shows an outline of the different protocols. So it definitely gave me some confidence how to lead people through these kind of protocols in my own clinic. John, is this something you've tried with people, these micro-inductions or low-dose initiations?
I've done it in the hospital, and I've tried it outpatient a couple times. It seems like it's something that you're struggling with, right, when you dip into it, but it works in some patients. It seems like it's not like a slam dunk by any means, but it's useful for a small subgroup.
Well, hopefully you'll be able to use it in the hospital more. We just got IV buprenorphine approved on our hospital formulary, so that'll help our low-dose initiation protocols.
It's cool.
Yeah, stay tuned.
Awesome. All right. So last article. So this one was a pretty good conversation generator. It's episode 60. The title was Lisdexamfetamine, the treatment of methamphetamine dependence. It was a randomized placebo-controlled trial from addiction and from December 2024. The question was, does lisdexamfetamine reduce methamphetamine use in individuals with methamphetamine dependence compared to placebo? Number 2 is lisdexamfetamine safe for this population? So that would be kind of brand name Vyvanse for those of you kind of listening right now. This was a phase 3 randomized double-blind placebo-controlled trial involving 164 adults with methamphetamine dependence at 6 Australian clinics. And it was assessing the impact of lisdexamfetamine, 250 milligrams a day for 12 weeks on methamphetamine use and safety outcomes. That is a whopping dose. I believe that the maximum FDA-approved dose is 70, so it's pretty high. Results, in terms of the primary outcome, there was no significant difference in methamphetamine use in the last 28 days of treatment between the groups. So that was the primary outcome. Basically, week 8 through 12, was there a difference, and did it last after the trial, or as the trial went further? So no difference that last month of the trial. In terms of secondary outcomes, total methamphetamine use over the 12 weeks of the trial, there were about 8 fewer days of methamphetamine use in the lisdexamfetamine group. And I kind of tried to wrap my head around these conflicting findings. And basically, when you look at the graph kind of per week, really, there was a substantial reduction in illicit methamphetamine use the first month of the trial. And then as the trial went on, they kind of converged with the group receiving placebo. And by the time it hit after a couple of weeks, like that 6 to 8 week mark, it was the two groups were basically hand in hand with similar rates of illicit use. There was no sustained effect with reduction in methamphetamine use in the lisdexamfetamine group at the week 19 follow-up. There was no difference in abstinence rates, craving, withdrawal, or urine drug screen results. Patients that got lisdexamfetamine, they felt it was very effective and they really liked being on the medication. So that was highly statistically significant, which kind of makes sense. And I think that, it tracks a lot with other literature I've seen. I think I talked on the podcast about this, but a recent kind of perspective changing um, presentation on adult ADHD from one of our tertiary care hospitals in the area. They talked about that patients on stimulants, actually everyone perceives an improvement, but actually that doesn't correlate to functional outcomes, and actually there can be a difference between the two. So, and that makes sense. Like it's an amphetamine. Um, there was no difference in convenience or side effects. There was no safety difference between the two groups, which, that's a short duration. We do know that long-term stimulants do have an association with increased cardiovascular effects, even when prescribed appropriately. So I think that just relates to the short trial duration. And then in terms of like, do patients kind of like the methamphetamine, and do they feel like they have a high drug liking score? People really liked being on it again, like I said. So a lot of satisfaction and drug liking when you actually gave them this very high dose of lisdexamfetamine. So the conclusion here is that, while the first month did look kind of like a possible opportunity for a new treatment option for something we currently don't have any treatments for, as the trial progressed, there was really no difference between the group being treated with lisdexamfetamine and being treated with placebo in terms of methamphetamine use. So this kind of looks again at something I feel like we keep looking at this spot over and over again about amphetamines, lisdexamfetamine, modafinil, these kind of like prescription stimulants for methamphetamine use, and they continue to come up negative. So I think we got to look other directions at this point. We just keep doing the same thing.
We just keep hoping. Hope springs eternal, right?
Yeah, I mean, alpha's a 5% chance. I mean, how many more studies until we find one that shows a difference?
Well, it just makes so much sense. I mean, I think the two things, one, the plausible biologic plausibility that this would help, and also the fact that patients do like taking it. Patients do like taking stimulants and amphetamines. They feel good on them, and trying to sort of tease out how that's different from it actually helping with the stimulant use disorder, And then with all the people who have ADHD and actually do better with ADHD being treated, it's very hard to tease out, but the studies just keep showing it's not effective, unfortunately. That's it. We made it through all 10, and it's under an hour, barely. But more Addiction Journal Club, the better, right?
I guess so. I hope people feel that way.
They do. I can tell. Thanks, everybody.
Well, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join us on Facebook. The links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Keenan and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation, and have a great day.